Let's try, I'm here, so let's try 5-6. Shot. 2, 3, 4, 5, 6. It looks too low. Everyone stay where you are. Shot. I mean, I need to see better there, Jordan. I think I'm on right now. Give me an AP. Quickly. All right, folks, welcome to our broadcast of live surgery. We're doing a cervical Deuk laser disc repair. All right, lateral. Need to be a little bit more medial, which I can do. Shot. That's looking pretty good. I'm in the disc. Shot. I need a better view of that, Jordan. Give me an AP. Yeah, that would have been helpful. Just give me a quick AP. So right now I'm placing the needle, the spinal needle, into the spine. I want to be a little more medial. All right.
You got it right? Yep.
Shot. 2, 3, 4. There it is. 5, 6. Shot. That looks pretty good. Shot. I need to be just a little bit more. Shot. Superior. That's it. Right there. Shot. Give me an AP. Give me a coker. All right. Shot. That looks damn good. Take it. Let's go lateral. We're definitely in. I can feel us pass through the annulus. Perfect. We're right near the midline. All right, keep that picture. No problem. Well, let's clean this up. So first of all, I'm Dr. Deuk Majan. Clean up that picture. Welcome to the Deuk Spine Institute and Surgery Center Viera for our broadcast. No. You had it better when you were lower. I just need you to try to get rid of some of the white because you're over-penetrated. I'm talking to my staff, Jordan, who's, there we go, that's perfect. So you can see, show us C2 at the top, C2, 3, 4, 5, 6. The first disc we're going to work on today is number 5-6, just because that's where we happened to be when we went in, and we are doing 4-5 and 5-6. So our patient is having, has 2 herniated discs, one at C4-5, the other at C5-6. And we are starting with the 5-6. The procedure today is called the Deuk laser disc repair. And let's start by running a video showing our audience why people get neck pain from a herniated disc. While you're doing that, I'm going to do our discogram.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. All right, so you can see from the x-ray, let's switch over to the x-ray there. Jordan, show our audience where the guide wire is. Yep, that's the guide wire. Now, show them where the tip of the guide wire is, the back of the guide wire. Yes, right at the back of the disc. And show the audience the part of the guide wire that's actually inside the disc. Yep, right there, perfect. And show them the part of the guide wire that's not inside the disc, but it's inside the neck. There you go. All right. So that just shows you the different parts of the guide wire. The guide wire is literally that. It is a wire that guides. And what it's guiding is this thing right here. This is called the dilator. If you look at the tip of this thing, can you see that, Henry? The tip is tapered. It's designed to slide down the guide wire and go into the disc. All the way to the back. I got it. All the way to the back of the disc. All right. Then we got our 4mm incision, which we made while you guys were watching TV. Shot. Now I need to be able to see the back of that guide wire, so please get that cleared up for me. I need a little shoulder. That looks pretty good. I want to make sure that guide wire does not go deep. Shot. In other words, sometimes you can trap the guide wire with the tip of the dilator. So I'm going to hold the guide wire with one hand as I advance the dilator to avoid moving the guide wire forward. Forward would mean it goes into the spinal cord. Now, I'm at the front of the disc, at the anterior longitudinal ligament, and I'm pretty close to the midline. So we're going to get an AP and just verify that. AP means anterior posterior X-ray picture. All right, so you can see we're a little bit to the left of midline with the dilator tip, which is fine. You want to avoid going through what's called the longus colli muscle. Actually, we're a little bit off on the AP, so I think we're okay because it's a little bit rotated. You can see the incision here, right, Henry?
Yes.
That's the whole surgery. Fixing 2 herniated discs will be done with that tiny incision. Only endoscopic surgeons know how to do this. And in the United States of America, there's one that does cervical endoscopic, true endoscopic transdiscal surgery. That's me. What's that for? I'm going to try to advance the dilator through the front of the disc, into the disc. Once I get it started and I get into the front of the disc like I am now, now it's safe to take out your guide wire and advance the dilator through the jelly, the nucleus pulposus, to the back. All right, let's show our audience a video of what we're going to be doing once we get to the back of this disc, how we're going to fix it using the Deuk laser disc repair.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. So we're ready to place our tubular retractor. You all see this here?
Yep.
So when you do surgery on a person, you have to move the skin and tissues aside, unless of course you're operating on the skin. Dermatologists operate on the skin, plastic surgeons operate on the skin, but we're operating on a structure that's way deep to the skin, so we're gonna have to go past the skin, we're gonna have to go past muscles and blood vessels and esophagus and trachea and other tissues to be able to work on the spine. So to do that, we need to create a pathway for our tools that we need to use during the surgery. And that pathway is been determined by the needle position and the AP lateral fluoro, and it's preserved and maintained throughout the surgery by this tube. The whole surgery will be done through a 4mm tube, okay? and that's why the incision is 4 millimeters. So I'm going to bring this tube down, and once I get this in place, I'm going to bring the endoscope down the tube. You guys can see the endoscope.
Yep.
And the secret to doing endoscopic surgery is you need an endoscope. I get a lot of people talking about Laser Spine Institute, which is now closed for over 2 years. And they say, yeah, Laser Spine Institute, that's what Dr. Deuk does. He does laser spine surgery. No, Laser Spine Institute used the word laser as an advertisement gimmick, but they never actually used the laser. How do I know? My friends worked there. They're surgeons, and they said that, you know, they went there and they were trained on doing the surgery, and it was never a laser used at all. It was just used in the name. Now at Deuk Spine, we're actually doing a Deuk laser disc repair, which requires the laser for the whole surgery. Let me show you the laser. Can you see this?
Yes.
This is the laser fiber. The laser generator is a machine. It's over by the feet of the bed. It's about the size of a large suitcase. But the laser generator creates a small beam of energy invisible to the eye, and it has a little red targeting beam, which is visible light, so you know where to aim it. But this fiber is made out of glass, and it's coated with blue plastic, because we at Deuk Spine love blue. We're a blue company. But anyway, the blue fiber covering plastic stuff doesn't do anything, but it just sort of protects the glass fiber so that it doesn't break. But the energy is transmitted through this little clear fiber, and that's 0.5 millimeter, 0.5 millimeters wide. And you're going to see that in the endoscope in a few minutes. All right, so right now I've got to deliver this tubular dilator to the disc that we're fixing. All right, and that feels pretty good. Let's see where we are. That's it? Okay, good. So show them the dilator in the disc. You're looking at the x-ray?
Yes.
Show them the dilator. Run your arrow along the dilator. Show the tip of the dilator at the back of the disc where the tear is and the herniation is. Good. Show them where the tube is, right there. Okay, you can see a transition point where it gets wider. That's the outer tube. And the outer tube slides along the dilator into the front of the disc, and we're going to advance it to the back. You want to give some inline traction, please? Shot. So I'm moving the tube that I'm working through the disc to the back of the disc. Shot. You see that? It's almost there. We're just about there. Shot. That looks really good. So the tube, show them the tube, Jordan, where the tip of it is. Yep. And it's at the back of that disc. So the beauty of this procedure, and the problem is, literally in the United States, I'm the only neurosurgeon doing this, because other neurosurgeons are stuck in the past doing fusions or artificial discs. And both fusions and artificial discs are very invasive, damaging procedures that are completely unnecessary. 99% of the time they're done. They're unnecessary because this surgery should be replacing them. There's no metal being put in. There's no fusion being done. There's no artificial disc that could pop out. And there's no adjacent segment disease, so we're not putting extra stress on the discs above or below like a fusion and artificial disc do. A study just came out showing that artificial discs and fusions of the cervical spine both have the same rate of adjacent segment disease. So there's no benefit of artificial discs over fusion in preventing the next disc above and below to wear out. That's what the artificial disc companies were marketing for many years. Now they can't market that anymore because it's not true. We found out that fusions and artificial discs both have the same adjacent segment disease rate. That was a study that was published about 9 months ago. All right, we're going to put our irrigation on. We're going to go down the little tube, and we're now at the back of the disc where the herniation is. Can you guys see down the endoscope?
Yep.
Now while I get this focused, let's show our audience the comparison between basically open neck surgery, which is done for artificial discs and fusion, versus Deuk laser disc repair.
Deuk Laser Disc Repair. A comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Oh, wow. Hopefully you guys saw this giant herniation just sneak out. But since you've been watching that comparison video, we've started removing the herniations in the back of C5-6 disc, where the herniations are, through the annular tear. And you can actually, look at this big herniation right here. I'm just moving it around so you can see it move. It literally popped out of the epidural space where it was pushing on the spinal cord and nerve. So I'm going to go in there and I have to try to remove it with a grabber. So you want to turn the light on for a second and check this out. Go to the eye in the sky.
Yeah, we can see it.
So I'm going to take this pituitary rongeur and go down and try to remove that piece of herniation, and there it is, right there. You see that? Pretty cool, huh? It looks a lot bigger under the endoscope, but it's about 2 or 3 millimeters probably, maybe 3 millimeters or 4 millimeters maximum width, but you saw it filled up the whole tube, the inside of the tube.
Thank you.
All right, coming back. Good. Now, people ask me, and by the way, for those of you watching, you're welcome to ask questions. That's the whole point of doing the broadcast, is to teach. The reason why I do the broadcast here at Deuk Spine is for education. And why do we want to educate? Well, what you're watching today, me do, is exactly how surgeons are trained in their training programs. They learn surgery by coming in the operating room and standing next to the primary surgeon who's doing the surgery they're attending, and they literally watch what the surgeon does. And by being in the operating room, they're learning how to do the surgery, okay? And that's exactly what I'm doing for you all, people watching this. I'm giving you an opportunity to learn just like a real surgeon would learn, in the same exact environment. You're just not standing in the operating room. You're literally watching everything I'm doing, so you're getting even better than a resident in a way, because residents in training, their legs get tired and they don't have access to popcorn and Diet Coke like you guys do. So you can sit back and watch the surgery being done, and in the comfort of your home or office, and learn what it is we're doing here and why we do it, without actually having to go through a medical school and a residency. So I'm giving you the same opportunity a surgeon would have at the highest level of training, fellowship, in a specific area of neurosurgery, which happens to be spine surgery, and specifically minimally invasive. And I'm letting you watch exactly how a fellow who spent their whole life up to and in their 30s, learning, going to college, going to med school, going to residency for 7 years, You're in that 7th year of residency right now with me. You're side by side learning like a fellow would. So it's an incredible opportunity for learning that I'm providing you through Deuk Spine's educational videos and watching live surgery. So please feel free to ask questions if you have them. These are all little fragments of herniation. That is the annular tear. You can see the edge right there in front of the laser. And the golden color stuff is calcium, calcification. Now at 3 o'clock you see kind of like a ridge. That's the back of the end plate of C4. No, C4-5? Sorry, C5. And then on the left is the back of the superior end plate of C6. And those fibers right there running up and down, left and right, are the posterior longitudinal ligament. And right here is just a little bit of herniation stuck down. Now we don't want to get too cute, trying to remove every last smidgen, because those little pieces don't do anything. Here's some more herniation here for little fragments. Here's another one right there. So I got to float these guys out like Pennywise. Now the herniation doesn't like me very much because I'm here getting rid of it. Okay? Now feel free to type up your questions. We'll be happy to answer them for you if we can. Keep them on topic, which is spine. Anything to do with spine, whether it's physical therapy, pain management, just don't get political with me, and I won't get political with you. We can talk about a little bit about racing if you have an interest. Talk about Deuk Spine Institute's sponsorship of a top race car driver and team that will be on ESPN next year and racing over in Europe with the Formula One teams. Not on a Formula One team, but on a Formula 3 team, which is the 2 levels below Formula One. But let's try to focus on spine questions, if you will, and I'll be happy to answer them for you. This is a big piece of herniation here, all scarred up. I have to get through the scar tissue. Now this patient comes from Washington, the state of Washington, I believe, correct? And he's had pain in his neck and radiculopathy now for, gosh, many years. 2006. Spot on. 2006. And, you know, he's seen all kinds of neurosurgeons at UC San Francisco and all kinds of top clinics around the country, and they've got great neurosurgery in Seattle, you know, Washington. And he's talked to the top surgeons, and guess what? They've all offered him either a fusion or an artificial disc. And those are old technologies. They're metal, and they have a high chance of failing. I'm going to have to get this out because you can see that's where the nerve root starts right there. That is the dura, the covering of the nerve root. And I have to, this is off to the right. This is just a huge herniation and scar tissue. So I'm going to have to blast through it. We're just going to keep working on it. While I'm doing that, I'll talk to you till we get rid of this stuff. You can see the golden color means that it's calcifying. But this patient has suffered for years. Very smart man, very well educated. I know he's even been to Johns Hopkins and worked there. And actually, I can't give any details, but all right, irrigation is the irrigation okay? Because we're starting to see a little more blood. And we're not doing anything to see more blood, except the irrigation seems like it's died down. Now what we call these little things, I call them fumaroles. Yeah, please stay on top of that. Okay, you got to be watching that. All right, see what happens when the irrigation's working versus when it's not. And you get the fumarole effect, which makes it impossible to do the surgery. This surgery must be done with irrigation, just so you know. And the irrigation does several things. It removes the blood, but it also makes it visible for me to see what I'm doing, the surgeon is doing. But it also cools the laser, cools the tissues, because the laser can generate heat. And a lot of these articles written about lasers and spine are written by doctors who don't do laser surgery, they have no clue what they're talking about. They're just bashing it, even though they've never done it. The difference with me is I've done all the surgeries on the spine. I've done artificial disc surgery, I've done fusions, I've done laminectomies, I've done foraminotomies, I've done microdiscectomies, and I do endoscopic surgery. And since I do all surgeries on the spine, I'm able to say what's the best treatment. And on a scale of 1 to 10, the Deuk laser disc repair endoscopic surgery we're doing right now is a 10. It's the best. Fusion is a 2 or a 3. Artificial discs are maybe a 2. And laminectomy is a 1 or a 0 to 1, somewhere in there. There's no comparison between endoscopic, what we're doing, and metal surgeries that cause all kinds of pain and suffering and bleeding and scar tissue and hoarseness and difficulty swallowing and complications with the hardware and failed fusion and artificial or adjacent segment disease and loosening of screws, backing out of screws, loosening of the cage or plate. The artificial disc pops out, there gets an infection. You get a heterotopic ossification, which means that your bones auto-fuse together basically. You get ossification in places it's not supposed to. You get bone formation in places not supposed to happen around the nerves and spinal cord. So there's a lot of badness that comes with artificial discs and fusions, which hopefully you've picked up on with the video. All right, the video touched on a few points comparing Deuk laser disc repair versus open surgery like artificial discs or fusion. But there's a lot of things it doesn't touch on, such as the complications that occur in detail, which people who have open neck surgery for their herniated disc or bulging discs or stenosis, they're going to suffer with those surgeries tremendously because they're so invasive. Okay. I actually, of interest, on our Facebook channel yesterday, I had to kick somebody off because one thing we don't tolerate on our Facebook channel is misinformation. And when I have people misinforming other people on our Facebook group site, which is Spine Surgery Support Group, I can't have people getting misinformed. So I'm just thinking about a comment that was made by one of our members on that group where they were talking about, oh, they have scoliosis, but the Deuk laser disc repair couldn't possibly work for that. That's not true. Deuk laser disc repair works for scoliosis, but we don't fix the scoliosis with the Deuk laser disc repair. What we're doing is we're fixing the disc because that's where the pain is coming from. It's not coming from scoliosis. And, you know, a lot of people don't understand that. They think the pain is coming because they're told by other healthcare providers, they're misinformed. They're told that scoliosis is the source of the pain, but it's not. Stenosis also doesn't cause pain. Stenosis means narrowing. Folks, what causes pain is pure and simple. One thing: inflammation. Inflammation. Even when you have a tumor in your spine, tumors themselves don't cause pain. It's inflammation associated with the tumor that causes the pain. So as the tumor starts killing your own cells, or parts of the tumor itself dies, that promotes inflammation. And inflammation is where pain comes from. Whether it's pain in your neck or pain down your arm, it's from inflammation and inflammation only, not compression. That's why surgeons don't do surgery normally when they don't see compression, something pinching hard on the nerve root. They send the patient to pain management. The reason we send the patient to pain management is the pain management doctors treat inflammation, either with pills called anti-inflammatories, which don't really work, or with shots that are anti-inflammatory shots, okay, like an epidural steroid injection. But none of those treatments by pain management doctors actually work to give long-term relief. By the way, look at all this mass right here. I've been whittling away at. You see all that thing? See how it moves? It's literally a herniation sitting on top of the nerve on the patient's right side. And in the nerve it's sitting on top is at C5-6, so that nerve is the C6 nerve root. That goes to the biceps muscle, and it goes to the thumb usually, okay? So that nerve is being crushed right here. So this patient has inflammation from the herniation, which has caused all the scar tissue you're seeing, the white stuff. Plus there's the blue, which is the actual herniated nucleus pulposus, okay? I'm removing the herniation, which is causing the inflammation, which is causing the scar tissue. And literally it's right on top of the nerve, and I'm peeling it away. Remember, that glass tube you're seeing right there is 1/2 millimeter. 1/2 millimeter. So you can see the amount of control that I have of removing the herniation is about 1/5 of 1/2 millimeter. So it's around 10% of a millimeter. So the laser allows me as a surgeon to be extremely precise at removing just the part of the herniation, even though it's sitting right on top of the nerve. How many people have had open neck surgery like ACDF where they wake up and they have new numbness or weakness they didn't have going in? Why do you think that is? Well, it's because the surgeon either did damage to the nerve during the surgery, or they didn't get all the herniation off, okay? So it's important that you can see what you're doing so you can do it right. Okay?
We have multiple questions.
Let's go with multiple answers.
All right. The first question comes from Abhay on YouTube. And they asked, how do you deal with the upper part as it's the sensitive zone as compared to the other cervical spines?
Okay. I am not sure I understand the question, Ate. I'm sorry. How do I deal with the upper part as it's the sensitive zone as opposed to other parts of the spine? I think you're asking me, how do I deal with the cervical spine versus lumbar and thoracic? Or lumbar?
He added before in quote, similarly, herniation also leads to LTC2 and C3, and then he asked that question.
Oh, I see. So is he asking about adjacent segment disease?
I would believe so. Yes, that's what he just replied back. Yes.
Okay, so we are not creating adjacent segment disease. And the nice thing that we do here at Deuk Spine is we treat all of the herniations at one time. So you don't have to keep coming back getting multiple surgery. The number one reason, in my opinion and experience, for adjacent segment disease is not really that the fusion or artificial disc cause it. It's that it was there before and the surgeon just didn't fix it. They only fixed one disc. Why? Because, some of them are not comfortable fixing more than one disc at a time. It takes more time and effort. Already their surgeries could be lasting for 4 or 5 or 6 hours. They don't want to do a surgery for 8 hours because they're fixing 2 discs. So there's a lot of surgeon reasons. It's all surgeon, by the way. Reasons why they don't fix all the discs. So in my opinion, adjacent segment disease is primarily due to surgeons not fixing all the bad discs during their surgery. So it's really the surgeon's mistake, okay? Does the fusion cause those already damaged discs above and below to wear out faster? Yes, for sure. But I think that those discs were already damaged to begin with, and that's what we're seeing is a progression of that damage. Not that the fusion causes it, it's that it's already there. Maybe it's to a lesser extent on the MRI. Maybe it's not as symptomatic, but that's why there's so many failed surgeries, folks. It's honestly because the surgeons are not treating the patient properly to begin with. And that all comes down to making the right diagnosis. So there's a failure of diagnosis and a failure of treatment as the main reason for adjacent segment disease. The second most common reason, in my opinion, for adjacent segment disease is that the alignment of the spine is not done properly. So when you go into a fusion, if you don't get that curvature back and you fuse the patient with abnormal curvature, they're going to basically fight that abnormal curvature for the rest of their life until something gives away. You understand? If you have an itch, you're going to scratch at it. You just don't even think about it, you just scratch at it. So when you, as a surgeon, if you don't put the spine back in proper alignment, the patient will try to put the spine back in proper alignment after surgery. And they will fight and fight and fight. And they're going to fight against that bad alignment. And what's going to happen is they're going to force the disc above the fusion to move in such a way that it creates a failure of that joint over time, because they're forcing it to move abnormally. Remember, discs, they want to be what we call neutral. They want to be in their neutral zone. They want to be, in a position where there's no real force on them, where there's no tension, there's no stress force. They want to be in a neutral alignment, neutral position. It's called balance. They want to be balanced, okay? And when you don't fuse properly as a surgeon, when you fuse in a bad balance position, the patient is going to fight that bad balance subconsciously every single day, and sometimes consciously, and they're going to rip up that disc above the fusion to basically force it into a position that's comfortable for them, with their eyes on the horizon. I've been teaching this for years. All right, I've done everything I can do here. I cannot reach any further across. I've opened up the foramen as much as I can. That's the nerve root right there, that thing. And that material is sitting right on top of it. It's not putting pressure anymore. I've peeled away as much as I can safely. Let's see if I can try to do a little more. To do that, I'm going backwards, and then I have to go forward. Yeah. And it's really, if you think about it, I'm going forward then backwards. But what's the next question?
Next question comes from Tumelo on YouTube.
Hi, Tamela.
And they ask, "Hi, Dr. Amazing. Informative page. I own a medical sales company in South Africa and have new reps and watch your videos all the time.
Oh, thank you.
My question is, you mentioned previously that your patients are all outpatient. Do
Yes.
they go to an outpatient facility or go home after the procedure? And if outpatient, how long before they are discharged?"
Well, first of all, thank you for joining us. It's a pleasure and honor to have somebody like you here. All of these surgeries are outpatient. Every one that we've broadcast for the last 10 years on our YouTube channel, including the fusion surgeries. If you go back and watch some of our fusions on the YouTube channel, every single surgery, no matter how old the patient is, we've done outpatient fusion on 90-year-olds. They all go home within 2 or 3 hours of surgery. So we're the world's leader in outpatient spine surgery as well, not just endoscopic outpatient. These surgeries are all done at a surgery facility at Deuk Spine. It's not done at the hospital. None of these surgeries are done at the hospital. The reality is the hospital would not spend the money to buy the equipment years ago when I wanted to start doing these procedures. So I had to buy it myself, and we had to build our own surgery facility, and that's what we've done. And I'll be honest with you, it's the best decision I made in healthcare, besides becoming a neurosurgeon. Why? Simply because, unfortunately, in the United States and probably other countries as well, there's this hospitals where we had to go in the past to do surgeries. They're controlled by business people, and business people sometimes make bad decisions about medicine in terms of what equipment they should buy and what staff they should hire. Business people are always looking for less expense so they can make more profit, okay? And that's not how I conduct my business. I look at making the best quality so we get the best results for the patient. And you're switching the irrigation? Yeah. When you do that, you get great results. Patients are all happy. They have relief of their symptoms, and they come back to you if they need anything, and they send their friends and family to you. And so that's how we've grown our business. You know, we don't make money by cutting costs, you know. Of course, we don't want to be wasteful, but in the end, we buy the best equipment, the best supplies, the best medications, and I spend the money on those things, but the hospital wouldn't do that. The hospital didn't want to spend any money. I would ask the hospital for one piece of equipment that costs $10,000 that I feel is necessary to help my patients to have better results. And the hospital would say, we're going to take it to the committee. We're going to review it, the request, and the committee will decide. Well, the committee was made up of my competitors, you know, the surgeons that don't want me to be successful because I'm taking business from them. So it was made up of their friends, you know, their cronies. And so what I found is, we call it politics. The hospitals are full of politics, and a lot of it is anti-competitive, and it stifles, you know, the new technologies and the new ideas. You know, it just doesn't support it. So I realized I had to buy the equipment myself. And so I made the investment myself. My wife and I did. She owns the company with me. And we decided to spend, you know, $15 million basically to buy to build the building and build the surgery center and buy all the equipment. So it was a personal investment in believing this was what's right for the patients. And I have no reservations that I did the right thing. It's been hard, you know, for us financially to be outside the hospital. I'm not done.
Not done? Okay.
But it's from a quality of care and freedom to care for my patients the right way. It's been the best decision I made. And I knew it was going to be a good decision because I talked to a lot of surgeons that used to work in the hospital. How's our irrigation? Is it good? They used to work in the hospital, and then they built their own surgery centers for like ophthalmology and other specialties. But they were very happy having that ability to control the patient experience. We call it the patient experience. So hospitals talk about having a great patient experience. Some of them are really good, but the reality is the hospital is motivated to save money. And one of the ways that they're doing that right now is they're hiring nurses to do anesthesia. And my personal opinion and my professional opinion is, so they're a very good nurse anesthesiologist, don't get me wrong, but when it comes to spine surgery, I want a medical doctor who's really good at what they do to be here taking care of my patients. And the reason is simple. It's not about the easy patients that do well. It's about the tough patients that create, you know, risk and problems during the surgery. Oh man, I think there's a big herniation.
Lights on, please.
Yeah, look at that. Look at that herniation, guys. Can you see that?
Yep.
That is huge. Look at that. That is so cool. So, you got a good picture of that?
Yes, we did.
Thank you. Yeah, so it just comes back to really control of the entire patient experience and making it as good as can be. Personally, as a doctor, I made a commitment when I take care of people that I'm going to do the best I can. And, you know, we as doctors have to loan money for our patients to get their treatment because we actually have to pay all the bills, even though we don't get paid for maybe a few months or even years. So I realized I was already spending my money, you know, on investing on patient care. So why not spend a little more and really completely control the whole patient care episode? So that's why we built the Deuk Spine Institute to basically make sure that our patients have the very best medical care possible and not let the hospital committees and people who don't want that interfere. So yeah, I appreciate your comments. Hopefully you understand my comment. These are outpatient procedures, all of them. They're all done outpatient. We don't do any of them at the hospital. And I haven't done surgery at the hospital probably in at least I don't know, 6 years, 7 years, I stopped going there. And I'll tell you why. When I was going there, taking some, Medicare patients there who needed fusions done, because Medicare won't pay for them in the surgery center, I was taking the Medicare patients to the hospital, and they were getting complications like pneumonia from the anesthesiology, okay? Because if you give the patient too much fluids, they're gonna get fluid in their lungs, and that turns into pneumonia. And if you're not careful with how you extubate them and treat them, then they vomit, and that vomit goes into their lungs, and they get what's called an aspiration pneumonia. And that was happening it was really happening. Any case is too much, but I never had that problem with my anesthesiologist at the surgery center. So the problem at the hospital is they have one anesthesiologist who's watching 5 nurses, and those nurses are basically a lot of times unsupervised, because the nurses are, they have, if there's a patient having a problem, the anesthesiologist has to go there and deal with that patient. And they leave the nurses alone to extubate and recover the patients. And if the nurse, they don't hire nurses because they're quality. They hire the nurses because they're cheap. And unfortunately, you get what you pay for in medicine. If you pay cheap, you get cheap, bad care. I'm sorry, but that's the truth. And if you invest in high quality care, you get the best results. So it all became a control issue for me. And that's why we built our outpatient center. It was all about really having the best of the best of the best for the patients, and not having bad people making bad decisions that affect my patients. So Deuk Spine is really, in the year 2022, has always been an extension of my personal philosophy in healthcare, which is give the patient the very best possible care you can give them. Give them the very best of everything. And when you do that, it's like making a wedding cake. If you put the best batter, the best ingredients, the best icing, and the best design, you're going to have the best wedding cakes. So, not that I do wedding cakes, but the point is that anything in life, if you put the best into it, you get the best out of it. So that's a philosophy my father taught me, and he was a doctor, and he's passed away, but I know that he would agree 100% with what I'm doing for people. It's funny, I asked my father one time, because I was about 6 years old, and my dad was in the office, and I went to visit him. He was taking care of patients, and I was just a little kid, and I said to him, "Dad, how come you have so many patients?" And he said, "Because I give my patients the very best care, and that's why they come." So anyway, hopefully I answered your question. We're done here. We've done everything we can. I think that if you look at the foramen over there, there's still some scar tissue, which I'm very hard to get to, because of the patient's shoulders are blocking me. I just cannot get over there. And as I try, it's rotating my laser out of position. But that stuff right there is not pushing on the nerve anymore. I may be able to get a little more. It's actually just on top of the foramen. It's not in the foramen. So you can see the foramen down below escaping, the nerve roots escaping. This is all scar tissue, by the way. This is from what happens when you have a herniation from an annular tear at the back of the disc, that you get inflammation for years and years and years. And you can see the foramen is open right below my laser. There's nothing on the nerve down there. But this stuff, I just don't want it pushing back into the foramen. So I want to try to debulk it. It's like a tumor, basically. None of this is normal tissue right here. It's all inflammatory scar tissue from years and years and years of inflammation. That's about at least 10 to 15 years of chronic inflammation happening here at C5-C6. The C6 nerve root is free and clear. There's nothing pushing on it. You can see the gap down there. That's beautiful. Just a little bit of material here. I want to get that, and then we'll be done at this level. Okay? The other nice thing about the laser is that it does something other than vaporize. It actually creates a sonic wave that is very powerful. And if you've ever seen a sonic blast, you can feel what's called a concussion wave. And this laser creates a concussion wave. So everyone thinks the laser just works by vaporizing tissue. It also works by dislodging herniation fragments. You can see them all jiggling down there. Okay, so that's it. We've done everything we can do. The nerve is decompressed. I'm happy with the result. And I've gotten my workout for the day.
Thank you.
And look, you can see the angle that I've gone with this thing. You know, it's almost at a 45-degree angle. So I am going to put a little antiseptic. Antiseptic is antibiotic. Antibiotic means it kills biosis, which is bacteria. Biosis is life, but antibiotics are basically truly antibacterial, usually, sometimes antiviral, antiprotozoan, antifungal. Those are the 4 microorganisms, what we call microorganisms, meaning that you need a microscope to see them. And fungus, protozoan, bacteria, and viruses. Now, there is another organism called a prion. We talked about it last time. Mad cow disease, which we don't worry about too much because those patients all are pretty bad off with dementia. All right, so at this point, I'm going to come out with the tube. I'm going to leave the dilator, and we're going to advance the dilator up to the next disc. I use the fluid adapter to remove the tube. You have to. So this is the fluid adapter. Can you see that?
Yep.
We're going to bring our fluoroscope back in. And the nice thing about the surgery is it's essentially bloodless. There's no bleeding. You have a few drops of blood, maybe 10 drops, 20 drops of blood. I think it's 20 drops makes a CC. Is that correct? 20 drops to a CC. So, folks, open surgery for this patient would involve losing about 100 to 200. Sometimes surgeons will lose 500 milliliters of blood. We're losing 1. Okay, 1. All right, let's get everything positioned. We're not ready just yet, but let's get the fluoro in position. Are you happy with where you are, Jordan? Any questions?
Yes.
All right, just hold them for a moment. I got to reposition to the next disc. I want the head in neutral alignment in a moment. Just let me know when you're ready to do that, but don't do it yet. Fluoro's ready. And arm, shoulder, wrist are ready. All right, now let's go ahead and everybody do it. I need to see that dilator. Perfect. So I'm going to bring the dilator out of the disc, right to the surface. Don't move the head like that. And I'm going to be right in front of the spine. Right now, Sean, I could feel it. I'm literally in the front of the spine. Now I'm going to creep up to the next disc. Shot, come on. Shot. All right. I want to make sure I'm not getting off to the side, so I need an AP view. So we're going to go to an AP, anterior posterior view, front back view. Don't flex, whatever you do. There we are, we're in the middle. Good, now let's go back to a lateral. You can see the spinous process right below the dilator tip. You're going to see the esophageal temperature probe, which is that braided wire to the left of the dilator on the AP view. All right, now I got to make my way up to the next disc. Shot. Getting there, staying on the ALL. I am not coming off the ALL. If you come off the ALL, you are risking a lot of problems. AP, the ALL is the anterior longitudinal ligament. It runs in front of the discs, okay? You must feel it. As a surgeon, you must feel it and slide along it. It feels like a slippery line. No, give me your rule, AP, come on. Perfect, we're in perfect position on the AP. We're dead center. I want to look at the lateral, and don't do that. Go back to a lateral. Please don't hit the table. So the AP view is perfect. The lateral view is perfect. I'm going to anchor this thing, the dilator tip. Shot. Good, good. Raytech. We have a little venous bleeding. How do you know the difference between arterial and venous bleeding? It's simple. Venous bleeding is slow and dark red. Arterial bleeding is fast and bright red. Anybody know why? Shot? Come on, come on. Anybody know why? Shot? All right, drop the fluoro about 1/2 inch. I want to see the top of the spine just to be 100%. We don't need to be pulling so much on the shoulders. There we go. Shot. I want to verify our level. We call that localization. So there's C2, 3, 4, 5. Take. So we're in perfect position according to our fluoro navigation. We're in the right level or localized to the right level. Shot. Perfect. Sometimes we get a little tissue like disc material stuck in there. I got it. All right, we're going to do our discogram. Shot. Perfect. Look at the tear. Show our audience the tear, the posterior annular tear that Deuk Spine Institute discovered and described for the first time 10 years ago in our publication. That's it. And that's where the herniation has come out of, is that tear. Now we're going to go to the back of the disc and we're going to find that tear and we are going to debride it. And that's what we do with the Deuk laser disc repair. It's a debridement of that tear. By doing that, we get rid of the herniation. We also clean the tear so that the disc can now heal itself without fusing it. And that's the advantage of the Deuk laser disc repair, is no fusion is necessary, no artificial discs are necessary, because we're not taking the rest of the disc out. Other surgeons, they all take your whole disc out just to get to that little tear in the back. And they don't even do anything with the tear. They just go for the herniation that's sticking out the back of the tear. They leave the tear there, which is stupid because that's where more herniations are going to come. All right? And that's why they have to do a fusion. They've taken your whole disc out. So these patients that travel to Deuk Spine Institute from around the world, they understand the value of this procedure over any other type of surgery. Shot. All right, now as we advance our tube, show the tube with the arrow. There you go. Show it. Yep. The tube is sitting inside the neck. All right, show the esophageal probe. You see that braided fiber there? That's sitting inside the swallowing tube or esophagus. It looks like we're going right through it on the lateral view, but on the AP view, you know you're not. You're off to the side. And of course, there's an endotracheal tube, which you can barely see because we're overexposed. But that's it right there. All right, we're going to advance my tubular retractor down to the back of the disc where the tear was. And at the same time, I have to make sure the dilator doesn't go forward to the left because that's where the spinal cord is. We don't want that. That would be bad. Now, I can tell you, Sean, the Koreans who taught me this this technique of putting the tubes in, they've paralyzed a few patients, okay? And that's why they kind of stopped doing the cervicals for a while. But now they've learned my technique and they're starting to do them again. Notably, the most important thing that I do different is, one of the most important things I do different is I put the patient to sleep so they don't move around. The Koreans were doing anterior cervical transdiscal endoscopic surgery with the patient awake, moving around. Huh? My God, you would have a nightmare. I mean, I feel bad for their anesthesiologists. I feel bad for the patients, right? And the patients were moving around and they got paralyzed from, you know, the metal tube hitting their spinal cord and crushing it. So we put our patients 100% to sleep. They can't move even if they wanted to because we've chemically paralyzed them with a neuromuscular blockade. All right, let's take some of those questions while we're getting set up here.
First question comes from Reiko Pilot on YouTube.
Oh, Reiko Pilot, one of my favorite patients.
And they asked, how long does it take for herniations to calcify? And how can you tell how old they are by sight?
Yeah, so great co-pilot's asking, how long does it take for herniations to calcify? And can you tell if they're calcified before you start treating the patient? Yeah, so the answer is about 1 in every 500,000 herniations are calcified. Now let that number sink in. So how often, all I treat, Deuk Spine treats is pretty much spine problems coming from discs, herniations, and facets, and sacroiliac joint, piriformis muscles. But 95% of our patients have herniated discs. Okay? So I've seen a lot of discs over the years. I've seen MRIs of probably 1 million discs in 26 years as a neurosurgeon. So 1 million disc herniations. Of those 1 million disc herniations, I've seen probably less than 100 calcified discs. So that gives you an idea of the existence of calcified discs. They're rare, extremely rare. So rare, I honestly can't even remember the last time I saw one. Now, what happens is not calcification of the herniation, like as a dense calcium mass. What happens is you get, are we on with the laser? You get bone spurs forming. Now, bone spurs are very common, but calcified herniated discs are extremely rare. So if you're talking about a true calcified herniated disc, the only way to diagnose that, you can see it on an MRI typically, but you can also get a CAT scan, and the CAT scan will show you a huge calcium mass, okay? Again, extremely unusual. It's like finding dinosaur bones somewhere, that's how rare it is. It's so rare. Most herniations are soft, and like these, but they could be scarred up like these from years and years of inflammation. And most herniations have calcium in them, which are bone spurs, which we're removing. You see the gold color right there? That's calcification of the disc right there. But it's not a true hard calcified disc. It's a soft calcification, if that makes sense. So we see soft calcification all the time. All the time. Very common problem. All right. There's a piece of herniation that came out. Great question from Braco Pilot. Thank you for asking. Who's next?
Next question comes from Abhay on YouTube. And they ask, how do you identify emboli or any sort of clotting through this camera?
All right, sorry. How do you
How do you identify emboli or emboli or any sort of clotting through this camera?
How do you determine if there's emboli or clotting? Well, you just remember, if you go back a minute or two, you saw there was some blood clots when I first put the camera down. Those red things are blood clots. But emboli, I don't know what you mean by emboli. You mean cardiac emboli? Emboli to the brain? There's no way to identify that. No surgeon can identify that. So I'm not sure what you're talking about. If you're talking about a venous air embolism, that can be monitored with a Doppler on the precordial Doppler, which we never do because we never need to. So I'm not sure what kind of emboli you're talking about. Well, just to answer, emboli are usually things that travel in the bloodstream up to the brain or to the hearts or somewhere in the body. Emboli could be fat emboli, it could be blood clots, it could be air. So there's different types of emboli, but I'm not sure why you're asking because we don't get emboli in these surgeries. So we're not opening the venous system to air. We're not, fracturing bones to cause fat emboli. And there's no reason a patient would get another type of emboli, like a blood emboli. So I'm not really sure what you're trying to figure out, to be quite honest.
He replied vein emboli. Vein.
Venous emboli?
I
But we
believe.
have no reason to have a venous emboli. We're not opening a vein to the air. That happens in certain kinds of surgery, but not on neck surgery generally. All right, next question.
Right. Next question. This ain't even a question, but it comes from Reiko Pilot once more on YouTube. And they ask, tell us about racing. My granddad knew Smokey Eunuch, and I love racing stories.
I'm sorry. That is hilarious. Did you say Smokey Eunuch?
Correct.
Oh, wow. Do most people know what a eunuch is? I love it. Smokey Eunuch. That's so cool. Well, I didn't know that about your granddad. Very nice to know. So the racing is going to start. Actually, it's pretty exciting because the most supposedly the best drivers in the world race what's called Formula One. Most people have heard about it. It's not common in the United States, but it's becoming more popular and more people are learning about it. It's mostly a European series, but basically it's a race series where I'm noticing we don't have any irrigation, so it's racing that occurs around the world, okay? And I know they tried doing that with IndyCar, and they do that with football now, and they do that with basketball, right? Look at Brittany Griner. She's over in Russia in prison. There's something wrong. Give me a second, guys.
Or even the dilator if you want.
Yeah, the dilator might be better.
Yeah.
I don't know if I'm torquing it to the side and it's catching on the wall. Yeah, it feels pretty good. It must be the scope. I wonder if the scope is bent. The shaft could be a little bent. One of the nice things about this scope is it's fiber optic, so it's able to bend, which you want a scope that's able to bend a little bit. But for some reason, it's just getting stuck in the wall. Anyway, getting back to answering the question, Formula One is the highest level of racing worldwide. And unfortunately, there's no American drivers racing in Formula One because, well, there's a lot of reasons. But I don't want to go into that right now. But it's not that Americans aren't good enough. We do have drivers that are good enough to compete with the best European drivers, and most of Formula One has been dominated by European drivers. It's sort of a favoritism thing. Kind of like, I don't know, music used to be dominated by British bands, back in the 80s. And unfortunately, it's really hard to break in to the Formula One path as an American for a lot of reasons. One, you have to race over in Europe because the races all happen on European tracks, and the only way you're going to learn those racetracks, how to drive them properly, is to go to Europe and race in Europe. So that's very expensive, as you can imagine, to do, and without support of sponsors, it's impossible for regular people to do that. And so we need American sponsors to help American drivers. And the sad thing is there's a lot of American sponsors in Formula One, but they don't help American drivers. They help European drivers. And that's a bit of upsetting to me and the people like me who are involved in American racing, is that we've got Amazon Web Services, you've got what is it called? Client Resource Management. Help me out here. The CRM tool, they're a sponsor. Walmart is a sponsor. There's tons of American sponsors. Just go look up Formula One race and you'll see that there's literally 20 American companies that sponsor it. But they're sponsoring European teams and European drivers, okay? And Honda, for example, works with one of the teams, Red Bull, and they require that Red Bull have one of their drivers as Japanese. So Honda's a Japanese engine manufacturer, and they require a Japanese driver to be in Formula One. There's a Chinese driver now as well. And so it's very political, and there's just no American drivers. Now, there are a couple of American drivers just below Formula One. One of them is Logan Sargent. We've known Logan for years. He's a highest level American driver right now, in my opinion. He's a Williams reserve driver. So, you know, Williams is a British team. They've agreed to have him as a reserve driver, but he's not actually going to be racing in F1 next year. And then there's Jack Crawford, who's an American who has had 2 years in F3 to work his way up, and he's, in my opinion, has had tremendous support from Red Bull and from the top teams, and of course his father has supported him, but he hasn't really been able to do a great job. He's done a mediocre job, in my opinion. So there's not a lot of American drivers in this series, this ladder to F1, and Arias is going to be starting next year in one of the teams, a British team called, well, we think he's going to be in Carlin, but we don't know for sure yet. And they're one of the 10 F3 teams. So he will be racing in Europe and Asia. And what's exciting is next year there is going to be the F3 series, the Formula 3 series supports the Formula 1 series. So they're like the opening band for a big rock band. So imagine being the cover band or opening band for a giant rock band that everybody wants to go see. So that's what they're going to be. And they've added 2 races to the schedule for next year that they've never had before. The first one is Monaco. So we're going to be racing in Monaco with the Formula One cars, which is the first time in the history of Formula One in the streets of Monte Carlo. The second is Australia. The Australian Formula One race is on the streets of Australia. It's a street race. It's not a circuit. So that means that the other drivers that Arias races against, they don't have an advantage like they do now, where they can go test and practice all the time on the circuits. So it's going to be exciting to see how he does. Personally, I know all the American drivers. Hunter Yaney, Arias Dukmajian, was Sebastian Montoya at one point, but now he's going Colombian. And, Logan Sargent. There's a few that say they're American just so they can get the American sponsorship and support, but they're not really American. They've never been in America. We've never even seen them anywhere in America. Maybe they were born in the United States, but then they moved overseas. But they call themselves American so they can get American support. But I don't consider them real American drivers. Sorry. That's just my opinion. You have your own, I'm sure. But those are drivers like, I think Brad Benavides is one of them. So of the true American drivers, I think Arias is the most talented. So can he put it all together and have a great season? Time will tell. Maybe he'll screw up and it'll be garbage, and he'll end up just going to Princeton, and maybe he'll follow my footsteps as a neurosurgeon, as a backup plan, okay? But right now he's been accepted to Princeton. He's put it off for a year just so he could race, because racing is what he really, really loves to do. So I'm going to support him, and we'll see how our young American does next year in the FIA F3. But thanks for asking. All right, what other questions do we have?
No current questions, but we do have multiple comments. The first comment comes from Tumello, once more on YouTube. And he said, "Thank you so much for your answer, doctor. All the best to you and your team at the Deuk Spine Institute."
Hey, thank you very much. I appreciate that sentiment. All right, so already, and I'll take the other questions in a moment, you can see that this disc has less herniation. Remember, if you go back and compare it to the last one we just did, there was a ton of herniations in the back of the disc for the C5-C6. This one still has a mountain of scar tissue right over here off to the side. This is the right side, and he's got mostly right arm symptoms. So we've got to deal with this, but again, it's not as bad as it was at the disc above. So you can see how two herniations kind of look the same on the MRI, but they're very different when you get inside the disc. And this is going to be, we got 5 minutes, doctor. So I'm telling my anesthesiologist we should be done in about 5 minutes. That way he can start planning with the gas to wind it down a little bit and reverse the muscle relaxer so that we can be ready to wake up soon. Is our next patient here? By the way, we have 4 surgeries today. 3 of them are, I believe, cervical, right, Luis?
Yes.
Oh yeah, that was cool, huh? Big piece of herniation there. This is part of the annular debridement right here. These are chunks of annulus that are frayed. Frayed means ripped. And I need to clean these edges up so that this thing will heal properly. It's already looking pretty good. Definitely not as bad at this disc as the 5-6, so happy about that. What other questions do we have?
No current questions, but we have another comment from Facebook. This is from Julie Karak.
Hi, Julie.
And Julie commented, the images do not seem as clear as usual, and I'm not seeing any blue.
Oh, hi, Julie. Yeah, so great question. The images do not seem as clear as usual. I'm not sure why that would be. They are clear to me. You're right. The amount of blue you see is dependent on a lot of things, okay? Number one, how much did I actually able to squirt in? But more important than that, you've made a great observation, and I applaud you for it. Okay, so what is the blue? The blue is the dye staining to degenerating nucleus pulposus. So when you don't see as much blue, what that means is you don't see as much nucleus pulposus. And the reason for that is the nucleus pulposus that came out in the herniation is like totally scarred up now. And scar tissue doesn't bind the blue, only the nucleus does. So when you see a lack of blue, you're seeing a lack of acute herniations, which are usually about 1 year old, 2 years old. What you're seeing is chronic, old herniation that's scarred up. It's all white scar tissue. All this stuff I'm blasting right now is mostly scar tissue. So scar tissue doesn't stain blue, okay? So that's why you're not seeing as much blue as you would normally. You see the bone over there? That's the end plate. It's kind of pink. That doesn't stain blue. The cartilage on the end plate doesn't stain blue. Scar tissue doesn't stain blue. And the annulus fibrosus doesn't stain blue. So what you're actually seeing is mostly scar tissue, unfortunately. Scar tissue has been here for years and years, and it doesn't bind the blue Deuk stain. Okay, so just means that we have a different kind of herniation here that's been around for a long time. That white is scar tissue, okay? It's sitting right on top of the spinal cord. It's not doing anything to hurt the patient in any way, so you don't want to mess with it because you could end up damaging the spinal cord and then you really regret what you've done. So remember, everything I do, and people online love to challenge me, and you know, I have no patience for it, to be honest. I don't mind teaching, but I do mind these silly challenges from people who don't have the training, education, experience, where they start to challenge me on, well, things that I say are true, and I have tremendous amount of basis for it, evidence and experience for it, and they want to know, where's your evidence? And you know, I don't mind sharing a little bit of evidence here and there, but trust me, I've got more important things to do than to sit here and try to teach people that don't want to learn, okay? So that's one of my pet peeves, is people wasting my time. I don't mind. I'm here to fix people. I'm here to help them. I'm not here to do a debate, okay? I'm not a debater. You know, they want to debate a neurosurgeon because it's cool. You can tell all their friends, but that's not what I'm here for. I'm here to fix people that need help, and want to be fixed, that can be fixed. And so I don't like to do the debate, okay? Maybe someday I'll hire an official Deuk Spine Institute debater, to debate these yo-yos. But I'm not here for those people. I'm here for the people who are suffering and they want to get out of pain and they're looking for help, they're looking for answers, and they want to get better, or they know somebody who does. So, yeah. I think we're just about done, but let me see. Just be prepared, but don't do it yet. I need about a few more seconds. I just trying to float this piece out. All right. So what other questions can I answer? I think if you're running out right now, we definitely need a little more. It looks like you are. I need another minute or two, so we're just talking about the irrigation, folks. Yeah, it's fine. Thank you. All right. I don't know, did I respond to the comment in a way that they're looking for, or what?
I believe so.
All right, good. Any questions?
Other than that, we have a question, I think a comment from Julie from Facebook once more. And she asked, doctor asked why there was a difference in blood color with a U and / color with an O, or just with an O. My answer was oxygen. Thank you for your response to my earlier question. My surname is the same as Paul Carrack, musician.
Nice. Nice to meet you. You're correct. It is oxygenation of the red blood cells. And, you know, the difference between vein and arterial blood, ideally, as long as the patient's getting enough oxygenation in their lungs, is that the arterial blood is oxygenated blood. It has oxygen, high oxygen content. Most of the oxygen is found bound to a special type of cell called a red blood cell. Red blood cells have what are called heme groups, which is an iron metalloprotein that binds oxygen and transports it throughout your body. And when the red blood cells binds the oxygen, the heme group undergoes what's called a conformational change in shape. And because of that conformational change in shape, by binding an oxygen at its heme center, what happens is the heme group then reflects light in a different way so that it reflects more of the green, and the blood looks like, more greener rather than dark.
Did you lose the tetrameric binding?
Yeah, tetrameric binding means 4 sites. So why do I know so much about this? Because for those of you who aspire to do what I do, if you're in undergraduate, go and learn biochemistry. Biochemistry, I think, is one of the most important fields. If you want to be a doctor or a healthcare provider, you want to understand biochemistry and cellular biology. New areas are hot, like, genetics and molecular biology, which are important too. But the more you learn about science, the better doctor you're going to be, in my opinion. We're done. So we've taken the tube out. There's a small little cut on his neck, and I'm just putting pressure. If you do these kind of surgeries, you always want to put pressure for about 4 minutes. That's how much time it takes for a vein that's torn to seal off in a normal person with normal coagulation. Now, some people don't have normal coagulation because they've been taking non-steroidal anti-inflammatory drugs for years, or aspirin. And aspirin and nonsteroidals, they affect platelet plugs, and they affect the blood clot formation. So you could have to wait a little longer in certain patients. Also, certain herbals like turmeric and even fish oil will prevent your blood from clotting. But I don't think I went through a vein, but there's veins in front of the spine. They're literally right where the disc is. And if you watch my fusion surgeries, you can actually see those veins. We bovie them with a hot knife and coagulate them all the time. But I'm just holding preemptively because, it's the right thing to do. I don't want a blood clot. We've never had a blood clot in a Deuk laser disc repair, ever. And a lot of that's because we're holding pressure, because we keep the blood pressure low on the low side of normal. We don't let it spike up. We make sure the patients are off their antiplatelet therapy, off their anticoagulant, and off their non-steroidals, okay, and off their herbals. So we optimize this patient for surgery. It's called optimizing, and we monitor and manage the physical and chemical attributes that would precipitate excessive bleeding to minimize the risk of blood clots, okay? Plus the small incision is good. And let's see, it looks like there's no bleeding. Look at that, okay? Look at this right here. The whole surgery was done through that tiny hole. Now, had this patient had ACDF, they would have had an incision like this. Okay, and that's, if you're a good surgeon, that's a good incision. But there are even other incisions you can make, like from here to here. So this is transverse, this is oblique. Surgeons choose different options depending on what they're comfortable with. But the whole surgery was done through that little cut. So hope you enjoyed it. If you have questions, type them up right now, and I'll be happy to answer them face-to-face in our post-surgery discussion. In the meantime, Henry, would you mind running a video for our audience so they can learn a little bit more about some of our patients who have had the Deuk laser disc repair for bulging disc or herniated disc or degenerated disc? This is Dr. Deuk Major. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. It just took a long time to recover from that. So this was much, much better.
Your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March. And I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
of
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries, he puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
Surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
all the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, 2 of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. But most of the time, it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks. We'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck, and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery. And I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser.
Yeah.
And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means. It's because I hurt so bad. I'd never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yeah.
we did your surgery. You went home an hour after the surgery, back to your hotel with
Yeah.
your lovely family who I met.
Yeah.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I'm just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome. Hello, I'm Dr. Ara Deuk-Majan, and we just completed fixing 2 herniated, degenerated discs in the neck. And surgery went very well. Our patient's traveling here from Washington. He has had these 2 herniated discs for some time, years. He's sought other opinions on how to treat them. He's been recommended by other surgeons for more traditional surgeries like fusions or artificial discs. And I myself have done over 1,000 surgeries with fusions and artificial discs in my career, 26 years. And we have really just completely moved away from this. Why? Obviously, you don't want metal bolted to your spine. It's not normal, it's not natural. You're losing flexibility of your neck. You're gonna create scar tissue from those surgeries, bleeding, lots of bleeding, injuries to your swallowing tube and arteries and veins in the neck and soft tissues. And that's if you have a good surgery and it goes well. There are horrible complications that happen with patients that have fusions and artificial discs or laminectomies. Those complications that I've seen, not in my patients, but in other surgeons' patients, include dying, strokes, holes in their swallowing tube from the surgery that render them on a feeding tube for the rest of their life. Lots of pneumonias and heart attacks, and all kinds of bad things happen to people potentially that are having fusions and artificial discs. The risk goes up dramatically for complications. And then you have the complications of not fusing. Say your bones don't make it together, they don't mend. Then you have a non-fusion or failed fusion or pseudoarthrosis, different names for the same thing, which causes complications. You can have hardware complications where the screws back out or get loose, and then you have to have revision surgery, and they have to extend the fusion to other levels. So why go through all that risk of complications, bad outcomes, problems, just for what? To get your arm to feel better? Fusions are not even designed to fix neck pain or headaches that come from herniated discs. But the Deuk laser disc repair procedure you just watched is. The whole purpose of the procedure is to eliminate the arm symptoms, which is weakness, numbness, tingling. That's from a pinched nerve. Eliminate arm pain, which comes from inflammation of the nerve root called radiculitis. Elimination of headaches, which is called cervicogenic headache. It comes from inflammation of the dura covering around the brain, which starts in the neck, actually starts all the way down the bottom of the spine and goes up around your brain. So inflammation in the back of the disc gets on the dura, causes headaches. And then getting rid of neck pain, which comes from inflammation, again, in the back of the disc. So our Deuk laser disc repair procedure can fix a lot more than a fusion can fix, okay? And what it fixes is the source of the symptoms. Now, I get questions all the time from people who say, hey, I've got back pain right here, and I've got scoliosis. Well, I got news for you. The scoliosis is not the cause of your back pain, period. I've learned this. Now, most doctors don't know this, and they're going to tell you you need to have the scoliosis straightened out in order to get rid of your back pain. But that is not the case. And many people who have scoliosis that underwent the fusion surgery on their lower back to fix the scoliosis, well, they have worse pain now than they did before their surgery. So all that metal and scar tissue and dead muscle and bone, all that to get what? Worse pain? No, thanks. So why do we create the Deuk laser disc repair? Less invasive. You saw it was done through a little cut, 4 millimeters. More successful at getting rid of neck pain, headaches from the neck, arm pain, and unpinching the nerves roots, causing weakness, numbness, tingling in the arms. Then we also created it for a faster recovery. When you get a fusion surgery, when you're getting a piece of metal put in your neck, you're going to be in the hospital for a few days usually. Our surgeries are outpatient. The patient goes home in an hour. Okay? Also with fusion, you're going to have to take painkillers called narcotic painkillers, opioids. And people who have spinal fusion in their neck, they're usually on opioids for years after surgery because of the pain from the surgery. Yeah. Chronic pain from the surgery, unfortunately. Happens all the time. Our patients that have this surgery you watched today, the Deuk laser disc repair, 0 narcotics, none. We don't give any narcotics. Our patients take usually Tylenol, anti-inflammatory, and a muscle relaxer called Robaxin for 1 night. And generally they're out of pain by the next day. Now, we do have some people who have more protracted pain. Maybe they are on higher doses of painkillers and they have other issues. So about 10% of our patients that have this surgery are going to continue to have some post-operative pain after surgery, usually related to tolerance to pain meds or coming off the pain meds and having that rebound pain, what we call when you're coming off of medications. Or they could have facet joint pain. So remember, with the Deuk laser disc repair, we're actually fixing your disc. We're not doing anything with the facet joints. Now, about 10 to 15% of our patients have facet joint pain also, in addition to disc pain. We can't tell that until we fix the disc. And then they come and they say, oh yeah, I have pain twisting my neck, and it's back here on the left or right or both sides, and we have to go in and do what's called a rhizotomy, where we kill the pain nerve to the facet joint. So just some food for thought, but the Deuk laser disc repair itself compared to fusions also get facet joint pain afterwards. So that's probably not any different if I had to guess. But you have preserved movement, you have a very quick recovery, you have no narcotic painkillers, you have a small 4 millimeter incision, there's no scar tissue, no trouble swallowing or hoarseness. You know, you have a sore throat from the tube being down, but my gosh, the benefit of the Deuk laser disc repair over traditional surgery like fusion and artificial disc is massive for the patients. All right, do we have any questions? We don't. So at this point, I just want to say thank you for joining us. The surgery went very well. The patient should be discharged in about an hour. We're going to have him wake up, see how he does. But like I said, most of these patients are offered different types of surgery, open surgery, which they don't want. They find us in our less invasive treatment, and they look into the Deuk laser disc repair. And thank God we have a lot of educational material out there on the internet, either on YouTube or the website, so they can actually go out and learn about this procedure and how much better it is than open surgery. So thanks for joining us. We'll be back in about 45 minutes for another surgery on a young man who comes to us from Nicaragua, and he's actually originally from the Northeast in Pennsylvania. And he's just was talking to him a few minutes ago, getting him ready for his surgery. He's going to have 2 discs fixed, number 3-4 and number 5-6. So we're skipping a disc and fixing 2 discs, but we'll skip. We'll probably do 2 separate incisions. I've already told him that. He's okay with it. And he's got, again, what we call a disc bulge, which is a small herniation, but it causes a lot of problems for him. So join us in 45 minutes for another